3 16-year-old girl with abdominal pain and bloody diarrhea. Maggie Mahoney and Ryan Shermore. So the initial presentation, this was at a clinic 5 weeks prior to her admission to MGH. She presented with bloody diarrhea, abdominal pain with no swelling. She had fatigue, weight loss, and anorexia. She complained of joint and muscle pain. No fever or ulceration or rash was present on the subject. She had dry mucous membranes, and she was prescribed ciprofloxacin for a potential infection. The regimen was 3 weeks. So the personal and family history of the patient: she had obesity. She had frequent interactions with animals through her school. She'd been taking fluoxetine and dextroamphetamine and amphetamine for ADHD and anxiety. She had a family history of autoimmune diseases on her mother's side, GI disease on her father's side, and her mother had had a first trimester miscarriage. All right, so at MGH, the first lab results were taken at admission as well as hospital day 5. As you can tell looking at this chart, there's a significant change from day 1 to day 5. When she presented at the hospital, she had a already low hemoglobin and hematocrit range. Hospital day 5 it even increased further. Her platelet count was on the low side, but still acceptable reference range for a person of her age and female. But by day 5 it decreased to 67,000. The reference range, low range, as you can see, is 150,000, so this is extremely low. Indicates her body will be unable to properly clot in the event of injury. It also indicates that she probably is already clotting. Her white cell count is very low, is in the reference range on admission, but becomes high about 5 days later and increases further. Her D-dimer level wasn't taken at admission, but on the 5th day is noted to be extremely high. This is indicative of clotting in the body. Her ESR is particularly high, again indicative of inflammation in the body, as well as her C-reactive protein being high, which is also indicative of inflammation in the body. To go back to the hemoglobin and hematocrit, hemoglobin levels being low is concerning because it means that she's not going to be able to properly transport enough oxygen to her organs. And her hematocrit being low is actually further concerning because it means that the oxygen she does have is lower percentage in the blood. All right, so this is taken from the esophagogastroduodenoscopy. They took a camera and stuck it down her esophagus. As you can see here, 2 ulcers present on the wall. They are not related to any kind of bacteria due to that ciprofloxacin 3-week regimen.
That's on the esophagus?
Yes, I believe so.
Yeah.
And then inflammation here is hard to see, but the reddening and these spots here, as well as the walls kind of expanding a little bit, that's inflammation further along into the esophagus. All right, this is taken from the colonoscopy. This is the first image. Looking at this image, there's really not much to see here. It's pretty much just a normal image from a colonoscopy, but as you progress further into the sigmoid colon, you're going to see lesions forming on one side of the wall and swelling somewhat, just a little bit of inflammation on the left side. And then it progresses even further where it becomes circumferential. And actually, the way the colonoscopy works is that they inflate it by putting pressurized air into it. So this is actually just the colon unable to expand due to in the colonoscopy.
You said sigmoid colon? Where is that?
The sigmoid colon, right around here.
No.
Oh,
is that where I know?
This is still the sigmoid colon, yeah.
Yeah, okay.
All these images are taken from the sigmoid colon. This is actually, these 3 come from the first colonoscopy taken. They were unable to proceed further because they were afraid of poking a hole in the wall since they couldn't get through this lesion. And finally, taken from the second colonoscopy, this image F shows that they were able to get the colon open. However, it's completely circumferential with the lesions. Extremely painful, and there's actually oozing blood present here in the colon. Then we have a collection of CT scans coming up in the next few slides. These first are axial and coronal CT scans. So the axial CT, you can see here we're looking at the kidneys, and you can see in the kidney this fact that it's not all monochromatic. When they pipe enhancement in for the CT, you'd expect it to be each organ that has the same amount of relative blood flow to be the same color. The fact that you can see these big patches of graying and that it's not quite as bright as that means that there's some kind of lesion or some kind of blockage there stopping the enhancement from showing up. You can see it again here, with discoloration here, here, and here. So there's just some pretty significant lesions that are blocking blood flow. Then we have some more coronal CT scans, looking particularly at the sigmoid colon here and here. As you can see, these two masses here are just masses of inflammation or lesions inside of the colon that are stopping blood flow in the area. It's really quite concerning because it means that the colon probably isn't getting enough blood flow in that area. All right.
So was that necrosis that we were seeing in those original colonoscopies? Was that necrotic tissue? Or what?
Yeah, I believe so. All right, then an angiogram showing as the enhancement flows in from the shoulder here and down into the pulmonary arteries. And you can see here that this artery, this branch artery, is just not, the branch pulmonary artery is just not full of blood. So this is what you would expect it to look like. This is what an enhancement artery should, or vein should look like, this very bright white surface. And as you can see right here, it's almost hollow on the inside, which means that there's really almost no blood flow, or there's severe lack of blood flow. And this is very close to where they put the enhancement in, and it's very close. It's on the pulmonary artery, it's right next to the heart here, so it's a pretty severe clot right there, and it's indicative of thrombosis.
Why doesn't it want to go?
Oh, maybe click.
Here and there.
Okay, there we go.
All right, on the left here we have an MRI. The MRI is taken of the main portal vein, and as you can see here, you actually can't see the main portal vein. This right here is the main portal vein. This red spots right here, that's what blood looks like, any kind of flowing fluid, that's what it shows up as. You can see here there actually is a blood vessel, probably right here, and it's not blood flow. And it's hard to see under this contrast, but if it was a little bit higher, you could see the main portal vein right here in between these two crosses. And there is just a black vacuum. There's nothing there, which means there's no blood flow in the main portal vein. Again, indicative of severe thrombosis. You can see here in the mesenteric vein that, again, the enhancement comes in looking like this. And right here, it's being blocked by an organ, so you wouldn't expect to see it, but right here where the two come together is a black clot right there. So you again can see the blood flow being stopped by a thrombotic clot. Yeah.
So for the differential diagnosis, the first thing they considered was inflammatory bowel disease. This includes Crohn's or ulcerative colitis, because she had symptoms of diarrhea, abdominal pain, nausea, fatigue, and the high ESR, which indicates inflammation, and an elevated white cell count, which is another indication of an autoimmune disorder. But her thrombocytopenia is usually not indicative of IBD. Usually you'll see thrombocytosis, which is an increased level of platelets, and the extreme C-reactive protein level was too high for what would normally be expected of IBD. The rheumatologic conditions were also ruled in as an option initially because of the joint pain she was experiencing, the fatigue, the high ESR, and high C-reactive protein levels, but the predominance of GI symptoms in her initial case, the lack of a rash and the lack of arthritis were reasons they ruled these conditions out. Zoonotic infection was another consideration because of her high contact with animals from her school and the widespread manifestations of this disease. But if it were a zoonotic infection, they would have expected the presence of rash, fever, and neurologic symptoms in a better response to the antibiotic treatment initially administered. So this led them to their final diagnosis of catastrophic antiphospholipid syndrome. Catastrophic antiphospholipid syndrome, or CAPS, is a autoimmune disorder that affects blood clotting. It causes lots of thromboses because of the presence of antiphospholipid antibodies in the bloodstream. So the diagnostic criteria for antiphospholipid syndrome, not the catastrophic kind, is just more than one thrombosis in any tissue or organ in the presence of one of 3 different kinds of antiphospholipid antibodies. In her blood panels, they did find the lupus anticoagulant present in her plasma, but they were not able to find the anti-cardiolipin antibody or the anti-beta glycoprotein. These 2 are just another form of the antiphospholipid antibody, so only one is necessary for a diagnosis. She was able to be diagnosed specifically with the catastrophic kind of antiphospholipid syndrome because her syndrome was impacting more than 3 organs or tissues throughout her body. As you saw, Ryan showed many different manifestations of the disease. The rapid manifestation of her symptoms was also another reason that she was given this distinction, because you saw in the lab work it was only 5 days that it progressed so quickly. The confirmation of multiple small vessel blockages was another diagnostic criterion, and that lab confirmation of antiphospholipid antibodies, as I discussed on the last slide, was another criterion. So the mechanism for this disease, first, when you have antiphospholipid syndrome, antiphospholipid antibodies are present in the blood at all times, and they start to attach to cells within the blood. Specifically with CAPS, when you have these antibodies in the blood, it's triggered by another event. So in 61% of cases, this event is infection. So the doctors believe that she originally got an infection from her stool, zoonotic infection, that caused all of those GI symptoms and then caused the antiphospholipid antibodies to start reacting even more. How it works is these antibodies attach to endothelial cells, which line the blood vessels, monocytes, which are a type of immune cell, and platelets, and these cause expression of tissue factors, which form a complex with TF7 factor in the blood. And this complex causes lots of thromboses, as it says here, thrombogenic state. In addition, it causes complement activation, which means it's activating many proteins, a cascade of proteins in the immune system, and inflammation, and it reacts with the protein C, which explains her super high levels that we saw in the lab work. And all of this leads to just many blood clots throughout her bloodstream. To treat this, generally, the most success is found in a 3-point system of attack, but because of how severe her condition had gotten, they had to go with 5 points. So the high-dose methylprednisolone is a systemic corticosteroid, which was used for reduction of inflammation within her system. The IVIG treatment also helped with this. Rituximab and eculizumab are monoclonal antibodies, which are generally used to reduce the complement activation and reduce the presence of these antibodies within the bloodstream. And then the heparin was used as anticoagulant to break up all of the blood clots that were in her bloodstream. And eventually she was moved to a less aggressive treatment because that treatment on its own would have been very harmful over time.
Yeah. Notably, the heparin was changed to warfarin, just a less significant form of the drug.
And her steroid dose was taken down.
Yeah.
Any questions?